Hello, everyone. Welcome back to another day of our NCLEX review session. For those who just joined in our classroom, welcome back. And for those who are new to the channel, you are invited to stay with us for the duration of our session today. We will be tackling on the different NCLEX test questions on hyperparathyroidism and hypoparathyroidism. We are currently on day 72 out of the 90 days, and yeah, we're almost finished with the free sessions. However, we are inviting you to enroll to our comprehensive NCLEX course. So kindly visit our website at www.stancoast.nclexcoaching.com and also click in the description box below for that link, and make sure that you also hit the like and subscribe button, and make sure that you share this video to your friends who are also reviewing for the NCLEX. Our offering includes 3,000 NCLEX type of questions plus 200 NGN test questions. We also have the on-demand lecture videos and also the animated video series. So this is something that you can access for the entire 6 months with your subscription. So go ahead, please do that. Check the link below, please. And again, do not forget to like and subscribe our channel. All right, guys, let's proceed to our session. We'll have a first question of the day. Question number 1 states, a nurse is reviewing the clinical manifestations of primary hyperparathyroidism with a group of new graduates. Which of the following signs and symptoms should the nurse include in the teaching? Select all that apply. Is it A, muscle weakness and fatigue? B, salt and pepper appearance on skull radiographs? C, pallor and fatigue? D, hypertension and bradycardia? E, polyuria and kidney stones? F, loss of appetite and nausea? And letter G, hypocalcemia and hyperphosphatemia. We are tasked to answer this SATA, and you as a nurse are now reviewing the clinical manifestations of primary hyperparathyroidism. So which of those manifestations should you include in your teaching? All right. While waiting for your responses, I'm going to start doing the rationals. If you'd answered letter A, muscle weakness and fatigue, this is an incorrect answer. The reason for that is because the primary consequence of increasing parathyroid hormone secretion is hypercalcemia, which is the elevation of the serum calcium levels. So if we were talking about hyperparathyroidism, hang on a sec here, this is basically gonna show an increase in the activity, increased secretion of the PTH, the parathyroid hormone. Okay, and instead of having a this one, muscle weakness and fatigue, this is basically cause the calcium in itself, which is very high in this scenario. It is going to reduce the muscular excitability, and that is why they will have the general fatigue, and they will also have the muscle weakness. There is way too much calcium in the blood. Again, it will reduce the neuromuscular excitability. So that is the main reason why the person is going to have the muscle weakness and fatigue. So this is basically one of the correct answers. All right. We are talking about the hyperparathyroidism wherein there is increased PTH. that simply means that our patient will have hypercalcemia. And so one of the answers that we'll be picking in this scenario is the letter A, muscle weakness and fatigue. This is the primary consequence of increased PTH. And take note about the function of the calcium. However, if it is secreted or if there is excessive calcium level in the bloodstream, this will subsequently reduce the excitability of the muscles. So, correcting myself, this is one of the correct answer. All right. Letter B, salt and pepper appearance on skull radiographs. That's basically one of the correct answers as well. What does that mean when we are referring to that salt and pepper appearance? Remember, guys, when we have a increasing PTH, there is hypercalcemia. This is caused by the bone resorption, which simply means there is an increased osteoclast activity. Bone resorption. An increasing osteoclast activity is actually has a negative impact into the bone structure. It will cause the calcium ions to migrate from the bone tissue or bone structure into the bloodstream. And so that is why our patient here will have an increasing calcium level in the bloodstream. It's because of the shifting of the calcium ions into the bloodstream. That is because of the increased osteoclast activity. And again, what's the reason for that? This is caused by the increased PTH, or the parathyroid hormone. Again, this will cause shifting of the calcium ions along with phosphorus from the bone tissue into the bloodstream. Now let's take a look into letter C, pallor and fatigue. Well, fatigue is correct. However, pallor is not consistent with the manifestations in hyperparathyroidism. The problem here in this option C, the pallor, this is more associated with anemia, right? Again, it's not a typical feature in hyperparathyroidism. What about letter D, hypertension and bradycardia? We know that the excessive calcium level in the bloodstream can lead to the cardiovascular effects. It can lead to the high blood pressure because of an increase in the vascular resistance. The reason for the high blood pressure is the increased vascular resistance. Remember about its role in the contractility of the smooth muscles, especially the middle layer of the blood vessels. This is actually going to be much more contractile, or it will cause more of that spasm, or not really spasm, but constriction because of the increasing calcium content. All right, so the patient will have high blood pressure. However, the patient will have the slow heart rate, and this is because of the decrease in the cardiac excitability. There's way too much calcium. It will suppress cardiac excitability. Suppresses cardiac excitability. And so letter D is one of our answers. What about letter E, polyuria and kidney stones? Why? There is excessive urination in hypercalcemia. The reason for the polyuria is that excessive calcium level in the bloodstream can result in, the polyuria, it is caused by the decrease in the tubule's ability to concentrate the urine. That is why it's not able to hold the urine anymore. It will allow massive excretion of fluids by the renal tubules. Again, excessive calcium in the bloodstream can reduce its ability to concentrate. Decreased ability to concentrate the urine. And we are talking about the renal tubules here. Now, of course, if there is way too much calcium in the bloodstream, this will end up being excreted by the kidneys, right? So there is that hypercalciuria, presence or a possibility in the formation of those calcium stones. So we are also going to select letter E. What about letter F? Loss of appetite and nausea. Loss of appetite. Why? Is there something that, is this going to lead to that if there is increasing PTH and calcium? The reason why we're going to pick letter F as well, it's because with excessive calcium in the bloodstream, this can also reduce the gastric motility. Reduces gastric motility. And that is why they're going to end up with the nausea. This can also affect the digestive enzyme secretion. That is why they're going to end up with loss of appetite and nausea. What about letter G? Hypocalcemia and hyperphosphatemia. Take note that there is elevation of the PTH, which is the parathyroid hormone. This can lead to an elevation of the calcium in the blood. So we are eliminating letter G this time. Not hypo, but rather hypercalcemia. All right. The answer would be hypercalcemia, and there will be hypophosphatemia, not hyperphosphatemia. So we are eliminating letter G because increasing PTH can lead to excess calcium, and there will be hypophosphatemia. Remember about the inverse relationship between the calcium and the phosphorus? Hypophosphatemia. I don't have enough room in my slide today. All right, let's review. Again, if I mentioned letter A as incorrect option earlier, I apologize. That was an error. The correct answers are the following. We have letter A, B, C, D, E, and letter, A, B, not pallor. I'm sorry. Let me get this board or the slide cleaned. This is making me a little bit more confused this time. Hang on a sec. Our correct answers are the following. Letter A, we got letter B. We don't have letter C. We have letter D, E, and letter F. So except letter C and letter G. So those are the incorrect options, C and G. However, we have our correct answers, A, B, D, E, and F. A, B, D, E, F. All right, guys, I hope that you were able to get that clarified. Again, our patient has primary hyperparathyroidism. There will be an increase in the PTH. This will subsequently lead to the elevation of the serum calcium. All right, take note of those manifestations. It's very important. Now let's have a quick review regarding the regulation of the calcium in the body. And we know that our normal range is specifically set at 8.5 to 10.6 milligram per DL. And this is based on the consistent value that is seen in medicine books and also Lippincott. So we will stick with this value. All right. So this is where your patient's calcium level should be at 8.5 to 10.6 milligrams per deciliter. However, whenever there is an imbalance, for example, if there is hypercalcemia, if the patient's serum calcium level gets way too high, this will stimulate the thyroid gland to release the calcitonin. All right, so where is this calcitonin coming from? This is produced by the thyroid gland, and this is only released in response to a condition such as hyperthyroidism. hypocalcemia. Take note of the word calcitonin. All right. So what happens if there is now a secretion of the calcitonin in the bloodstream in response to the excess calcium level? This will now allow the deposition of those calcium ions into the bone. The calcitonin will promote these calcium ions to be stored into the bone tissues. Okay, so I would recall calcitonin as the saver. So this is that hormone that actually will deposit those calcium ions into the bones. I will call that as a saver. It tends to deposit calcium into the bank, right? Which is the bone tissue. Now, what's going to happen here if there is now deposition of the calcium salt or those ions into the bone matrix? This will now lead into the normalization of the calcium value in our bloodstream. However, if the exact opposite will occur, if there is hypocalcemia, which is another imbalance, right? What is going to happen here? In response to the decreased calcium level in the bloodstream, the body will respond by releasing the PTH, the parathyroid hormone. Of course, this is the hormone that is secreted by the parathyroid gland. Take note about the PTH. Again, this is only released when there is hypocalcemia. What will happen if this is released into the bloodstream? Well, the PTH will now stimulate the calcium to be released by the bones. Okay? So I will call the PTH as the spender, the hormone that will withdraw the calcium ions from the bones, from the bank. All right? So take note about the PTH. This is our spender. It will cause the release of the calcium ions from the bone matrix into the bloodstream. Why? Because there is low calcium level, right? He needs the money. That's why he is wanting to withdraw the money from the bank, which is basically the calcium. So when this happens, of course, this will lead to the set point back into the normalization of the calcium ion level, which is the 8.5 to 10.6. However, we do have another effect of the PTH. Another effect of the PTH is to stimulate the uptake of the calcium by the kidneys. Actually, this will cause the kidneys to reabsorb the calcium in the renal tubules instead of excreting. Since the body is actually sensing that there is a lack of calcium ions, then it will tell the renal tubules, hey, come back. We want you to go back into the circulation. And of course, this will lead to the normalization of the level as well. But we also have another effect of the PTH. What is that? This will also increase the absorption of the calcium ions in the intestines. So it will require more workload to actually absorb anything that is that has calcium content in the diet. It will allow more absorption of the calcium from the dietary sources. Okay, and so this will lead back into the restoration of the calcium level in the bloodstream. So again, guys, take note of the calcitonin. This is produced by the thyroid gland. This will be released when there is hypercalcemia. It will save the calcium, excess calcium ions into the bones. Whereas we have the PTH, which is the spender. It will cause the shifting of the calcium ions from the bone matrix into the bloodstream because of the lack of the calcium ions. So I hope that you will be able to recall these two different mechanisms, because this is very important in understanding our tests, our drill today. So let's talk about the second item here. A patient presents to the medical provider's clinic with hypercalcemia. The healthcare provider suspects primary hyperparathyroidism. Which laboratory findings would help differentiate primary hyperparathyroidism from other causes of hypercalcemia? Select all that apply. All right, so your patient has visited to the medical provider's clinic. Of course, they have hypercalcemia, right? So your physician is suspecting primary hyperparathyroidism. So which of the following lab values or findings would help in differentiating the primary hyperparathyroidism from other causes? So would that be A, low parathyroid hormone level, or B, elevated intact parathyroid hormone level, or C, increased urinary calcium excretion, or D, elevated vitamin D levels, E, normal or low parathyroid hormone related peptide levels, F, high serum alkaline phosphatase? Take your pick. All right, while you are selecting the answers, let's have letter A, low parathyroid level. This is incorrect. We are marking this one as error. This is incorrect. The reason for this one, okay, a low parathyroid hormone level is indicative of hypercalcemia that is caused by non-parathyroid conditions such as malignancy. It is not really, rather than being a primary hyperparathyroidism. Again, we are talking about a patient that has suspicion of primary hyperparathyroidism. Okay, so if you are selecting this low parathyroid hormone level, this is indicating that the hypercalcemia in this patient is caused by the non-parathyroid hormone or non-parathyroid conditions. It could be caused by malignancy, maybe myeloma. So it's not really gonna support that differentiation. What about letter B, elevated intact parathyroid hormone level? What is this? This is one of the correct answers, guys. The reason for that, it's because the elevation of the PTH in the presence of hypercalcemia is a typical characteristic of the hyperparathyroidism that is primary. Okay, primary hyperparathyroidism manifestation or assessment finding. Okay, so that is one. What about letter C, increased urinary calcium excretion? Is this correct? Remember that with hypercalcemia, there is going to be polyuria. So when you are selecting increased urinary calcium excretion, this is part of it. There is polyuria. There's also massive excretion of the calcium ions into the kidneys. That is why they are prone to developing the calcium stones. So this is basically that act wherein the body is trying to filter the excess calcium in the bloodstream. So this is one, hypercalciuria. What about letter D, elevated vitamin D levels? What does that mean? Well, it is not a correct answer. This is not a typical manifestation in primary hyperparathyroidism. Actually, what's going to happen instead is that an elevated vitamin D levels will contribute to the secondary hyperparathyroidism, not on the primary hyperthyroidism. So we are eliminating this one. What about letter E? Normal or low parathyroid hormone related peptide levels. What does that mean here? Normal or low PTHRP. This is what we call as the parathyroid hormone related peptide levels. This is going to help exclude the type of hyperparathyroidism that is caused by malignancy, which is pretty much like associated to that condition. Okay, so that is one. What about letter F? High serum alkaline phosphatase. This is incorrect. We know that the alkaline phosphatase may be seen in the bone resorption in a primary hyperparathyroidism, but this is not specific enough to differentiate the different causes of the hypercalcemia. Not really consistent in differentiating the different or the other causes of other type of hyperparathyroidism. So we are going to deselect that one. So we have our correct answers. Letters B, letter C, and letter E. Normal or low parathyroid hormone related peptide levels. A little bit complex type of question here. Now let's have number 3. A nurse is preparing a patient for a series of diagnostic tests to confirm primary hyperparathyroidism. Which of the following findings would support the diagnosis? Select all that apply. Is it letter A, elevated serum calcium and elevated parathyroid hormone levels? B, low urine calcium on a 24-hour urine test? C, increased bone density on dual energy X-ray absorptiometry, or known as the DEXA scan? D, elevated ionized calcium levels? E, hypophosphatemia. And letter F, high parathyroid hormone related PTHRP levels. Take note about the different diagnostic tests. You are preparing this patient for a different set of diagnostics in order to confirm their primary hyperparathyroidism. So, which of these items here will support the primary hyperparathyroidism? Would that be letter A, increased serum calcium? Yes, that is actually one of the correct answers, because when you have hyperparathyroidism, remember that it can lead to the increase in the calcium level. So that is one. And another is the elevation of the PTH, or the increased secretion or elevated PTH levels, which is basically what is circulating, causing the hypercalcemia. So this is one of the correct answers. So let's just list them one by one here. What about letter B? Low urine calcium on a 24-hour urine test. This is incorrect. We know that in hypercalcemia, there will be massive excretion of the calcium ions through the kidneys. So you will be seeing a lot of calcium in the urine, not low. This is incorrect. It should be elevated urine calcium. What about letter C? Increase bone density and bone density on dual energy X-ray absorptiometry DEXA scan. Is there going to be increased bone density? Remember that the parathyroid hormone will cause the bone resorption. It will allow the calcium ions to shift from the bone structure into the bloodstream. So it's not going to be increased bone density. It will be decreased. Okay? It's because of the increased osteoclast activity. So C is incorrect. What about letter D? Elevated ionized calcium levels. This is basically the unbound calcium ion circulating in the bloodstream. It will be increased because of the shifting of the calcium ions from the bone matrix into the bloodstream. This is correct. So this is letter D. What about letter E? Hypophosphatemia. Will there be a decrease in the phosphorus or phosphate? Yes. Remember about the inverse relationship between the calcium and the phosphorus or the phosphate? When there is excess calcium ions, this can increase the excretion of the phosphorus by the kidneys. That is why the patient will have low levels of the phosphorus in their bloodstream. Increases excretion of phosphate or phosphorus. What about letter F? High parathyroid hormone related peptide levels. Is this correct? Well, this is incorrect. The reason that this is incorrect is that the PTHRP is only associated with the malignancy-related hypercalcemia. It's not going to be elevated in a primary hyperparathyroidism, okay? Malignancy-related hyperphosphatemia. We are talking about a patient that has primary, not a secondary type, okay? Phosphatemia. Alrighty. Now let's talk about number 4. Babe, what is the difference between A and E? Are you referring to the... Oh, you're referring to question number 2, right? Boss babe? Letter E is related, the parathyroid hormone related peptide levels. This is related to a this is hormone that is actually going to be elevated whenever there is a malignancy related type of hyperphosphatemia. Okay, so this will really help out in differentiating the primary type of hyperparathyroidism with the other type of hyperparathyroidism that is caused by cancer. All right, could be caused by breast cancer, or could be lung cancer, or could be the multiple myeloma. So letter E would be helpful in differentiating that one. Okay. If you answered letter A, low parathyroid hormone level, this is not going to differentiate. This is not going to be much more of a specific testing. Okay, so that's why we are not selecting that one. So let's head out into answering number 4 this time. A patient diagnosed with primary hyperparathyroidism has a serum phosphorus of 1.7 milligrams per DL and a calcium level of 14. So take note about the values here. 14 calcium, 1.7 milligrams of the phosphorus. What nursing intervention should be included in the care plan? Is that letter A? Advise the patient to remain in bed at all times. B, recommend consuming 4,000 mL of fluids per day. Or C, implement standard seizure precautions for safety. Or D, check for the presence of Vostek sign. So again, our diagnosis is primary hyperparathyroidism. Don't forget about the levels of the PTH and also the calcium in the blood. Again, it's revealed that it's really high. There's hypercalcemia. So what would be your nursing intervention for this patient? Would that be A, B, C, D? What is your correct answer? What is the correct answer? All right. If you answered letter D, check for the presence of Shvostek sign. We are going to discard this one. We know that this is a manifestation of hypocalcemia, not hypercalcemia. This is the twitching of the face when you are going to tap the patient's cheek when they have a low levels of calcium. This will going to twitch. All right, that is the Shvostek sign. If you answered letter C, implement standard seizure precautions for safety. Remember that the seizure precautions would be appropriate in a patient that has hypocalcemia, not hyper. So we are going to discard that one as well. If you answered letter B, recommend consuming 4,000 mL of fluids per day. This is what we are looking for. We know that in hypercalcemia, there will be rapid excretion of the calcium ions through the kidneys. This will predispose the patient to develop the calcium stones. This will prevent that, allowing them to take in at least 4 liters of fluids per day. This is not done in one setting. No. This is to be distributed in the 24-hour period, okay? This will allow flushing of the calcium in the kidneys. So that is the correct answer. Letter B. If you answered letter A, advise the patient to remain in bed at all times. This will cause more bone resorption. Increases bone resorption. We know that if there is a decrease in the weight-bearing activity, if the patient is mostly in bed, this will decrease that weight-bearing activity, and we know that weight-bearing actually will allow the maintenance of the bone structure. It will keep the bone, the calcium ions into the bone matrix. It will not allow it to escape from the bone tissue. All right, so that is our correct answer. Letter B. We have to increase their fluid intake to about 4 liters per day. Let's have number 5. After undergoing radical neck surgery for a malignant tumor, a patient develops hypoparathyroidism. What should the nurse educate the patient about? Is it A, using biphosphonates to slow bone loss, or B, taking calcium supplements to stabilize serum calcium, or C, increasing fluid intake to prevent kidney stones, or D, adding whole grains to the diet to avoid constipation? Patient had a radical neck surgery for a malignant tumor. So after the surgery, they developed the hypoparathyroidism. So what you should do here as the nurse, will you teach them about the use of the biphosphonates to slow bone loss, or B, taking calcium supplements to stabilize serum calcium, or C, increasing fluid intake to prevent kidney stones, or D, adding whole grains to the diet to avoid constipation? If you answered letter A, using biphosphonates to slow bone loss, this is incorrect, because the biphosphonates are only used to treat conditions involving bone loss. It's not intended for a patient that has already developed the hypoparathyroidism, okay? Indicated for hyperparathyroidism, not for hypo. Take note about that medication. Okay. What about letter B? Taking calcium supplements to stabilize serum calcium. We know that there is going to be a low calcium level this time that the patient had developed the hypoparathyroidism. So this will help maintain their normal serum calcium levels. This is the correct answer that we are looking for. If you answered letter C, increasing fluid intake to prevent kidney stones, the fluid intake that is increased this time will no longer be necessary since the patient has changed its course. He's no longer hyperparathyroid, but is now in a hypoparathyroidism state. So we are eliminating letter C. Letter D, adding whole grains to the diet to avoid constipation. Remember, guys, that constipation is the manifestation when there is excessive calcium in the blood, right? So this is not going to be necessary this time. This is going to be counterproductive for someone that is having the hypoparathyroidism, okay? And another thing is that the whole grains may also decrease the calcium absorption. Take note about this. Whole grains can lead to a decrease in calcium absorption in the GI tract. So this is not going to help the patient that already has the hypoparathyroidism. Okay? Not going to be helpful. So we are going to select letter B. Now let's have number 6. Following a parathyroidectomy, a patient presents with carpopedal spasms and lip tingling. What should be done to provide immediate treatment? Your patient just had a parathyroidectomy. Now the patient is experiencing the carpopedal spasm. They also have the lip tingling. So what you should do here as the nurse taking care of this patient, we are being asked about immediate treatment, initial treatment. Would that be A, administer the prescribed muscle relaxant medication, or B, have the patient breathe into a paper bag, or C, initiate supplemental oxygen at 2 liters per minute via nasal cannula, or D, perform passive range of motion exercises on the patient? Your patient now has manifestations of hypocalcemia. So what would be your initial nursing intervention? Your patient has hypocalcemia. Take note about the lip tingling, carpopedal spasm. If you'd answered letter D, perform passive range of motion exercises on the patient, the passive range of motion exercise will not really impact the calcium levels. It's not a initial treatment for this patient. It will not affect the calcium level. We are required to do something that would initially treat the patient's hypocalcemia. This will not do that. If you answered letter C, initiate supplemental O2 at 2 liters via nasal cannula. Is this going to help the patient's hypocalcemia? No, it will not affect the calcium levels. It will not be helpful in relieving the manifestations of hypocalcemia. Again, no impact on the calcium levels. No direct effect. No direct effect on the calcium level. If you answered letter A, administer prescribed muscle relaxant, will the muscle relaxant relieve the spasm, the lip tingling? Yes, it might, but it will not address the underlying issue of hypocalcemia. This is only treating symptomatically. It's not going to, it's not targeting the underlying issue, which is the hypocalcemia. Only treating the symptom. So we are not going to select that one. Are you wondering why B is the correct answer? Have the patient breathe into a paper bag. This is only an immediate treatment. What's the rationale about having the patient breathe into a paper bag? The reason that B is correct, it's because the patient's act of doing this can temporarily help increase the patient's CO2 levels. Temporarily increases CO2 levels. And what is the relevance in increasing the CO2 levels in a patient with hypocalcemia? Well, the reason for that is because when you are going to get them breathe into the paper bag, this will allow the normalize the calcium level in the bloodstream. We are talking about if a patient is keeping their CO2 in their bloodstream, this will increase the CO2, right? So what's going to happen? It will decrease the level of, it will increase the level of the ionized calcium in the bloodstream. Increases the ionized calcium in the blood. That is the primary reason why we are going to let them breathe into a paper bag. Okay? It will lead to the elevation of the blood pH, which is actually going to allow the calcium to bind into the proteins, and it will allow rather the calcium to be much more present in the bloodstream. It will decrease its chances into attaching into the albumin. So please take note about this one. If the CO2 is increased, this will allow the calcium ions to detach. Detachment of the calcium ions from the albumin. So this is what we call as ionized calcium. They are not attached to the protein, so they are freely circulating in the bloodstream. Okay, so again, if we are going to elevate their CO2 content in their bloodstream, this will cause those calcium ions that have been attached from the albumin, they will detach from those protein sources or in the bloodstream. They are going to be more available in the blood. So this is what we call as ionized calcium. So basically you are freeing those calcium ions that were previously attached to the albumin. So this will temporarily relieve the hypocalcemia. Again, only a temporary treatment. This is not going to last long. So you should carry out what the medical provider has ordered for you to do in treating the hypocalcemia. Probably the injection of the calcium gluconate. Okay. So again, this is a temporary action. This will not be recommended for long-term use. So the rationale again, for elevating the CO2, it is going to allow the detachment of the calcium ions from the albumin. They will be freely circulating in the bloodstream now. So this will somewhat kind of normalize the calcium level for a temporary period. All right. So I hope that you understand the rationale there. Let's have number 7. A 66-year-old woman has been admitted for pneumonia and her total serum calcium is 13.3 milligrams per DL. What other test might the nurse need to talk about with the patient? Your patient now has hypercalcemia. So what other tests might the nurse need to talk about with the patient? Is it calcitonin? Will that be catecholamine? C, thyroid hormone? Or is it letter D, parathyroid hormone? If you answered letter D, would that be the correct answer? Yes, of course. Your patient has hypercalcemia. 13.3. Classic hypercalcemia. Remember about the role of the parathyroid hormone. This is that hormone that causes the shifting of the calcium ions from the bone matrix into the bloodstream. So this will identify that the patient has an elevated PTH. Okay? All right. If you answered letter A, calcitonin, we know that this is another hormone, right, that can regulate the calcium or the balancing of the calcium. But at this point, when the patient has this type of hypercalcemia, the PTH is more critical in this context. We know that the patient that has a hypercalcemia, or let's say in the normal regulation, as we are recalling that diagram that we had earlier, when there is hypercalcemia, the thyroid gland will allow the release of the calcitonin, right? It will cause the calcium ions to be stored back into the bone matrix. But in this case, we are going to select the parathyroid hormone because this is the primary hormone that basically will be responsible more in regulating the totality of the calcium level in the bloodstream. Okay? Again, the PTH would play a much major role in the calcium regulation. Okay? Now, if you had answered letter B, catecholamine, what is that? This is pertaining to those epinephrine, norepinephrine. They are not quite related to the regulation of the calcium. So we are eliminating letter B. What about letter C, thyroid hormone? Thyroid hormones such as T3, T4, they are not primarily going to regulate the calcium levels in the bloodstream as well. So again, the PTH would be the correct answer this time. All right, remember about that hormone that is known to cause hypercalcemia. Let's have number 8. In a patient with chronic hypocalcemia, which lab result is most likely to be seen? Is it A, an elevated PTH level, B, an increased calcitonin level, C, an elevated potassium level, D, a decreased vitamin D level? So this is quite similar to the prior question. Your patient has chronic hypocalcemia. Which laboratory result is most likely seen? Chronic hypocalcemia. All right, let's try eliminating letter D, a decreased vitamin D level. We know that vitamin D is responsible also in the calcium absorption, but the level of the vitamin D it does not directly indicate the presence of chronic hypocalcemia. Not a reflection of chronic hypocalcemia. So we are not going to select this one. If you answered letter C, elevated potassium level, there's no relationship with the potassium level and also the hypocalcemia that is chronic. It's not going to be affected. If you answered letter B, an increased calcitonin level. Increased calcitonin level. Well, if you have an elevation of the calcitonin level, this would cause a decrease it will decrease the calcium levels further. It will not alleviate the hypocalcemia. Again, letter B, increase calcitonin level. This would typically decrease the calcium levels, but it will not alleviate the hypocalcemia. Take note, guys, that our hormones, PTH and the calcitonin, they are going to be released in response to something problematic. Okay? So letter B is incorrect. If you answered letter A, elevated parathyroid hormone, when the patient has chronic hypocalcemia, their levels of the calcium is very low, the body will be tasked to increase the secretion of the PTH hormone because they have a low calcium level. Please, I'm confused. In the previous slide, you said increased calcium level, calcitonin is released, and hypoparathyroidism is that again? You said increased calcium level, calcitonin is released, and hypoparathyroidism is released. Can you explain more for me? Okay. So, take note, guys. Our issue here is basically the low calcium. Decreased calcium. So, the answer is letter A. Why is letter A the correct answer? This is the body's normal response to correct the low calcium. Remember that the parathyroid hormone will cause the release of the calcium ions from the bone matrix. It will allow the calcium ions to be released into the bloodstream. PTH will release the calcium from the bones. So when you are checking the patient's PTH, we are talking about the level of the hormone. This will be elevated, and this is because the body is trying to correct the low levels of potassium. Okay? Calcium is released. Are you pertaining to number 7? Question number 7. All right, let me clarify this one. Let me read back the situation one more time. A 66-year-old woman has been admitted for pneumonia and her total serum calcium level is 13.3. What other tests might the nurse need to talk about with the patient? The reason that we are going to select letter D this time, remember that the PTH, if there is hyperparathyroidism, remember that it will allow increased secretion of the parathyroid hormone in the bloodstream. Yes, it can do that. But taking into the consideration about the effects of the PTH, remember that the PTH will withdraw the calcium ions from the bones. And what is the result of that shifting? It will cause the calcium ions to saturate in the bloodstream. That is why this will lead to hypercalcemia. Please, my question is about the previous question. Boss Babe, are you pertaining to number 7, which is this one? Or is it number 6? I'm not quite sure which question you are referring to. If you answered letter A in item number 7, the reason why it is incorrect because the calcitonin is not the reason why the patient has hypercalcemia. It is the PTH. So while you clarify your question, I will proceed with item number 9. So kindly indicate what question that you are referring to so I can answer appropriately. Now for number 9, for a patient diagnosed with Paget's disease, which laboratory finding is most characteristic? Is it A, elevated parathyroid hormone and low calcitonin levels? B, low serum alkaline phosphatase and calcium levels? C, high serum alkaline phosphatase with normal calcium levels? Or D, elevated calcitonin levels and low parathyroid hormone levels. Your patient has Paget's disease. So I want you to recall what this condition is. Your task here is to identify that laboratory that will support that condition. Will there be elevation of the PTH and low calcitonin? Or is there going to be low serum alkaline phosphatase and calcium levels? Or is it C, high serum alkaline phosphatase and normal serum calcium levels? Or D, elevated calcitonin levels and low parathyroid hormone levels? So what would be that diagnostic test that will support? Very tricky, Petra, very tricky. This is a topic that is not quite discussed, not taken into a lower and higher degree. So this is the day that we should be talking about it. Your patient has Paget's disease. So what is the Paget's disease? Let's identify what this condition is. We know that when a patient has a Paget's disease, this is basically a condition that is not quite known yet as to the cause. So I want you to recall what this condition is. So a Paget's disease is basically a characterized by an overactive osteoclast activity. Initially, this will lead to the bone resorption. That is the initial phase. And once this is going to cause the calcium ions to escape from the bone matrix into the bloodstream, this is now going to stimulate what we call as osteoblast response. So this will follow the increasing osteoclast. Increased osteoblast. Remember about the osteoblast. Those are the cells that will help in the formation of a new bone. So in Paget's disease, this will now follow the first phase, which is the osteoclast. So once the body has sensed that, hey, we are getting way too much of this calcium in the bloodstream this time. So the body will compensate by doing the increased osteoblast activity. However, the osteoblast can actually be not, it's not going to really repair the bone structure. It will be characterized as, it's not a stable type of a bone structure. It is abnormal bone structure. So again, when we are talking about Paget's disease, it's going to involve the two phases. First is increasing osteoclast activity, followed by the osteoblast activity that is also increased. Now, this is a disease that is not really quite known as to the cause, right? This is commonly occurring in patients that are over 40 years old. This is more common in countries in Europe and also Africa, Asia. But when we are talking about the Paget's disease, again, there will be a different structure of the bone here. The bone is becoming larger bone structure. Even though it is quite big, they are weaker bones. It is less dense and it is going to be more prone to fractures. High risk for fractures. Okay. Now let's go back into the scenario here. For a patient diagnosed with Paget's disease, which laboratory finding is most characteristic? Is it A, elevated parathyroid hormone and low calcitonin levels? Or B, low serum alkaline phosphatase and calcium levels? C, high serum alkaline phosphatase with normal calcium levels? Or D, elevated calcitonin levels and low parathyroid hormone levels? The correct answer for this test item is letter C, high serum alkaline phosphatase with normal calcium levels. Take note, guys, that the body has already compensated by allowing it to increase its osteoblast activity. So this is now going to allow the return of the calcium to be deposited back into the bone structure. Normal calcium levels. However, they're going to have high alkaline phosphatase. And the reason for that, it's because the patient around this time has already increased, they have already developed that bone remodeling, okay? Again, the alkaline phosphatase is increased. It's because they have already have that bone remodeling, okay? Not low. If you're going to compare it to item or letter B, low serum alkaline phosphatase doesn't reflect the remodeling of the bone structure, but rather letter C is going to represent that. There will be normalization of the calcium level in the blood, and there is also serum alkaline phosphatase elevation. Letter A is incorrect. The reason for the elevated parathyroid hormone, the reason why it is incorrect, it's because the Paget's disease does not affect the parathyroid hormone and also the calcitonin levels in this manner, okay? Not affecting the PTH and calcitonin. So this is going to be an incorrect option. What about letter D? Elevated calcitonin levels and low PTH hormone levels. The same reasoning. It will not affect the PTH and calcitonin levels. The reason that I'm including this test item, even though it's not really directed, it's not really a condition that is directly associated with the imbalances in the parathyroid hormone levels, but this is somewhat kind of like associated as to testing you guys in identifying the diagnostic test. All right, so the correct answer here is letter C, high alkaline phosphatase and normal serum calcium. Now let's proceed to number 10. I hope that you're still okay there. What level of physical activity should be encouraged for a patient with hyperparathyroidism? Is it A, strict bed rest, B, bed rest with permission to use the bathroom, C, getting out of bed to sit in a chair twice a day, or D, activity and walking as tolerated? Your patient has hyperparathyroidism. So what type of activity should be encouraged for this type of patient? Will that be A, B, C, or D? If you had answered letter A, that is incorrect because it can exacerbate the bone loss. Increases bone loss. Remember about the bone resorption, right? The lesser the activity or the lesser weight-bearing activity is, the more that it will allow the calcium ions to escape from the bones into the bloodstream. Bone resorption. Strict bed rest is not recommended. If you answered letter B, bed rest with permission to use the bathroom, you're also restricting the patient's level of mobility this time. This is not going to be helpful. I'm sorry, bed rest with permission to use the bathroom. Hang on a sec. Actually, I mistyped this one with bed rest with permission. Yeah. With permission to use the bathroom is correct. However, the bed rest issue is not going to be helpful. We are not promoting bed rest for this patient. We are going to encourage them to increase weight-bearing activity as tolerated, not bed rest, guys. Letter C, getting out of bed to sit in a chair twice a day. Will this optimally help the patient with the bone resorption? Again, this is limiting the patient's movement. It will not really help in preventing the bone resorption. Sit in a chair twice a day. That's a lot of an activity. So removing that one. If you answered letter D, activity and walking as tolerated, this is going to allow weight-bearing activity. If there is increased weight-bearing, skeletal muscle or skeletal activity, this will cause the calcium ions to be kept inside the bone structure. So make sure that you are encouraging this one, as long as the patient can tolerate it. So we are going to pick letter D this time. Very good, guys. You answered letter D. Wonderful. Number 11, a 28-year-old female patient with hyperparathyroidism is unable to undergo a parathyroidectomy. Has hyperparathyroidism, but is not fit to get a surgical procedure such as removal of the parathyroid gland. So which treatment which treatment options the medical provider may prescribe for this patient? Select all that apply. So basically what you're being asked here is to identify those treatment options that are going to be more appropriate for this patient that is not able to tolerate a surgical procedure. So will this be letter A, administration of alendronate, B, administration of cinacalcet, C, high dose of calcium supplementation, D, percutaneous alcohol injection of the parathyroid gland, or E, radio-guided parathyroidectomy? Non-surgical treatment. So which of these treatments would be appropriate for this patient that is unfit to get a surgical procedure, such as the parathyroidectomy? If you answered letter A, administration of alendronate, what is this medication? The alendronate is what we refer as a biphosphonate. Have you heard of this medication? It is classified a biphosphonate. This will improve the bone density of the patient's spine and also their hips. So this is going to be a suitable option for them if they cannot undergo the parathyroidectomy procedure. Okay, so this is one of the correct answer. This is a biphosphonate. Again, this is going to help improve bone density. If you answered letter B, administration of cinacalcet, what is this? A cinacalcet is what we call as a calcimimetic medication. Calcimimetic medication. What it can do is to activate the calcium sensing receptors, and it will reduce the calcium levels. Reduces serum calcium levels. Take note, guys, that your patient has hyperparathyroidism. They will manifest the signs and symptoms of hypercalcemia. Their blood level in their calcium is elevated. So we want to control that calcium, excess calcium level in the bloodstream by administering the cinacalcet. Again, it will reduce the serum calcium level. Okay. What about letter C, high dose calcium supplementation? We don't want any more calcium supplement for this patient that has hypercalcemia. This will aggravate their hypercalcemia. In short, if you answered letter D, percutaneous alcohol injection of the parathyroid gland, we are talking about injection. It is not a surgical procedure. This is basically one of those treatments that will relieve their hyperparathyroidism. And what is this procedure all about? This is going to this will involve the injection of the alcohol into the parathyroid gland, and this will reduce the activity of the parathyroid gland. So it will now result into a much more normalized calcium level, okay? Decreases the activity of the parathyroid gland. So the expected result here will be reduction in the PTH hormone and also the normalization of the calcium level. If you answered letter E, radio-guided parathyroidectomy, this is an incorrect option. This is a surgical procedure. And again, our patient is not fit to undergo this kind of procedure. So this will not be applicable treatment option for them. So we are eliminating letter A. So back to our answers. We have letter A, we have letter B, and letter D as well. So these are appropriate non-surgical treatment for this patient with hyperparathyroidism. Alrighty, let's have number 12. The nurse is caring for a 55-year-old male patient admitted to the MS unit with a diagnosis of hyperparathyroidism secondary to multiple myeloma. Hyperparathyroidism caused by multiple myeloma. This is not the primary type. Now, the patient has also severe hypercalcemia. Which treatment options are expected for managing this condition? Select all that apply. Is it A, IV normal saline, B, thiazide diuretics, C, loop diuretics like furosemide, D, oral biphosphonates, E, intravenous biphosphonates, F, delay treatment? Your patient has hyperparathyroidism caused by the multiple myeloma, and they also have the hypercalcemia. So which of these options are appropriate for the treatment? If you answered letter F, we are going to eliminate that right away. That's an easy target. We need to deal the patient's hypercalcemia. We are not going to delay the treatment, as we know that the hypercalcemia can lead to complications, especially cardiac dysrhythmias. We don't want that. If you answered letter E, intravenous biphosphonates, what are these biphosphonates? Remember that the administration of the biphosphonates is very necessary in order to cause the what? It will address the calcium that is so increased in the bloodstream. We are going to temporarily treat the elevated calcium level. Remember about the action of biphosphonates. So what do you think about the biphosphonates here? Do you recall those examples of the biphosphonate medication? What do you think about, and do you remember any examples of those medications? The reason why we are going to administer the biphosphonates is to inhibit the activity of the osteoclast. That is the primary reason. Drug action prevents osteoclast activity. Remember about the bone resorption. So we are going to reverse that one, okay? As we are talking about IV biphosphonates, this is represented by the name called Zometa. Are you familiar with the name Zometa or the zoledronic acid? This is the IV form. zoledronic acid, or Zomida. This is a very rare form of medication, and it's rarely administered in the med-surg units. I've rarely seen this one. But as we are talking about IV biphosphonates, it will have a much more rapid effect in decreasing the osteoclast activity. It will treat the hypercalcemia by reversing the effects of the osteoclast. It will prevent the resorption of the calcium, or it will prevent the bone resorption, rather. So this will have a much more rapid effect. So we are going to select letter E. What about letter D, oral biphosphonates? Will this treat the patient in the acute phase? Oral biphosphonate. The oral biphosphonates are actually helpful as well in treating the hyperparathyroidism, but in a case of a patient that has severe hypercalcemia, this is not really the drug of choice this time, because it will not really have a much rapid effect into the regulation of the calcium. So we are going to eliminate oral biphosphonate. So we have here the alendronate, right? Okay. Again, the reason that we are eliminating the oral biphosphonates, it's because they will not be effective in acute management. Not effective in acute management. Especially that our patient has severe hypercalcemia. We definitely need to treat that with a much more effective form. If you answered letter C, loop diuretics like furosemide, do you remember the effect of the Lasix? Loop diuretics, furosemide. Remember about furosemide. This is a very potent diuretic which can it can excrete the calcium ions in the bloodstream much more effectively. It will allow massive excretion of excess calcium in the bloodstream. So this is going to be one of the treatment modalities, furosemide. What about letter B, thiazide diuretics? Thiazide diuretics, remember about thiazide diuretics? They're actually going to lead to hypercalcemia. So we are not going to pick thiazide. Can increase calcium blood levels. Even though it is a diuretic, but it will not get rid of the excess calcium. It will rather increase the calcium ions in the bloodstream. If you answered letter A, IV normal saline, if you are going to treat this patient with hypercalcemia, severe hypercalcemia, we definitely need to allow hydration to this patient. We need to expand their circulating blood volume. This will allow the what do you call this? Dilution of the serum calcium. Okay, dilutes serum calcium. And the reason for the administration of the IV normal saline, it will also help prevent the dehydration, because again, our treatment will include the administration of the furosemide. So we want to make sure that our patient has enough fluid volume and make sure that they are getting that IV infusion while we are treating their excess calcium level by giving them the Lasix. So as you are going to get rid of the calcium by the administration of the Lasix, we are going to make sure that they are not going to be depleted in their fluid volume. That's why IV normal saline is one of the mainstays in the treatment. This will also flush the renal system from the kidney, from the formation of the calcium stones. We know that the direction of the excretion will go towards the kidneys, right? And we want to prevent that calcium stone formation by giving them IV normal saline infusion. All right, so our correct answers are the following. Letter A, we have to administer loop diuretics. We're going to give them a much more rapid acting biphosphonate as we are dealing with a patient that has severe hypercalcemia. Oh, wow. It's 10:27 my time already, and we are still on item number 13. Number 13, a nurse is providing education to a patient with asymptomatic primary hyperparathyroidism who is not undergoing surgery to evaluate the patient's understanding of their treatment plan, which statements made by the patient indicate they comprehend the instructions provided. Select all that apply. So your patient here has asymptomatic, that's good, asymptomatic, they have hyperparathyroidism. They're not going to get any type of surgical procedure to remove their parathyroid gland either. So you as a nurse, you're going to evaluate their understanding about their treatment plan. So which of those statements made by the patient indicate that they understand the instructions provided to them? Will that be A, I will engage in regular weight-bearing exercises to keep my bones healthy? B, I need to increase my calcium intake to at least 1,500 milligrams per day to prevent bone loss? Or C, taking lithium or thiazide diuretics will help me manage my calcium levels? D, I should avoid prolonged periods of inactivity to prevent worsening bone loss? E, I need to drink plenty of water to help reduce my calcium levels? And letter F, I will only need to monitor my serum calcium levels every 5 years unless I develop symptoms. So you are going to pick those statements that will show evidence that they definitely understand the treatment plan, since that they're not going to be doing the surgical removal of the parathyroid gland. They're only going to be doing it by means of pharmacologic therapy, or let's say dietary modification, or let's say what do you call this? Yes, dietary modification. So what would that be? Or which options should you select? If you answered letter A, I will engage in regular weight-bearing activities to keep my bones healthy. Remember about that. Yes, this is reflecting understanding about the treatment of hyperparathyroidism. The physical activity is going to strengthen the bones. It will prevent the osteoporosis. It will prevent the bone resorption. So this is correct. Okay, what's going on with my pad? Letter A. What about letter B? I need to increase my calcium intake in at least 1,500 milligrams per day. The patient is experiencing hyperparathyroidism and also hypercalcemia. They should not increase their calcium intake. All right? Not exceed. This is way too high. So we are eliminating letter B. What they should have instead should be moderate intake. And what does that mean? Moderate intake means that they are only allowed about 800 to about 1,000 milligrams per day of calcium, not 1,500. That is way too high. If you answered letter C, taking lithium or thiazide diuretics will help me manage my calcium levels. This is incorrect. We know that lithium and thiazide diuretics can increase the calcium levels. This is incorrect. Can result in hypercalcemia. And I've already mentioned this earlier in the previous item. The thiazide diuretic can cause conservation of the calcium ions And that is why we are not going to select that. Same thing with the lithium. It can lead to hypercalcemia. If you answered letter D, I should avoid prolonged periods of inactivity to prevent worsening bone loss. This is reflecting understanding. Very good if you answer that. If you selected letter E, I need to drink plenty of water to help reduce my calcium levels. E. The E, that is increasing fluid intake. Remember that this will dilute the bloodstream. Yes, this is also going to prevent the complications of developing kidney stones. So this is reflecting understanding as well. Okay. No worries, Petra. You're totally fine. So this is going to dilute their blood. Will also prevent hypercalciuria. This will prevent calcium stone formation. If you answered letter F, I will only need to monitor my serum calcium levels every 5 years. That is way too long to wait to get your blood monitored. The answer should be instead frequent monitoring. Not every 5 years. So we are not selecting letter F. Again, our correct answers here would be letter A. We have letter D and letter E. Again, wrapping this up, we need to encourage weight-bearing activity for this patient to prevent bone loss or bone resorption. We are also going to avoid or let the patient avoid increasing periods of inactivity. They should be adapting a much more active lifestyle, and they need to increase their fluid intake to dilute their blood, and this will also prevent the calcium stone formation. Alrighty, let's have number 14. A 54-year-old patient with CKD and vitamin D deficiency is being evaluated for secondary hyperparathyroidism. Which statements by the patient indicate an understanding of their condition and its management? Select all that apply. Your patient has CKD and has vitamin D deficiency. Guys, just want to mention right now that one cause of the secondary hyperparathyroidism is chronic kidney disease. Another is the cancer, which we already had earlier, right? The multiple myeloma type of scenario. So these are known causes of secondary hyperparathyroidism. So what would be your answers here? We are going to pick more than one option here. It says which statements by the patient indicate understanding of their condition and its management. They do have CKD. They also have vitamin D deficiency. Remember that the kidneys are responsible in synthesizing, also converting that active form. This will activate the vitamin D, right? And so if the patient has CKD, they will have low vitamin D levels. Now, they have been evaluated for secondary hyperparathyroidism. So your task now is to select those statements that they understand their treatment. Is that A, I need to increase my vitamin D intake to help manage my calcium and phosphorus levels? Or B, my parathyroid hormone levels are high because my kidneys cannot convert vitamin D into its active form? Or C, I should expect to have my calcium and phosphorus levels monitored regularly to manage secondary hyperparathyroidism? Or D, secondary hyperparathyroidism is primarily caused by an overproduction of calcium in my body? Or E, increased levels of fibroblast growth factor 23 will help reduce my parathyroid hormone levels. If you're not familiar with this one, that's okay. This is a much more complex level of testing in a patient that has a secondary hyperparathyroidism. So if you answered letter A, I need to increase vitamin D intake. Yes, that is one of the correct answers here. As we know that the patient with the CKD has low vitamin D. We need to treat them with the vitamin D. So if they said, I need to increase my vitamin D, yes, that reflects understanding. The vitamin D deficiency can lead to the hyperparathyroidism, right? So that's one of the correct answers. If you had answered letter B, my parathyroid hormone levels are high because my kidneys cannot convert vitamin D into its active form. Yes, of course. That's also a correct answer. Remember, guys, that the parathyroid hormone is activated. It is released in greater amounts when the body has hypocalcemia. Guys, in a CKD, the calcium level is very low. And that is why they will have elevation of the PTH. This will lead to that hyperparathyroidism. But this mechanism will not really resolve the hypocalcemia. It is not going to be an effective buffering system. Okay, let's have letter C. I should expect to have my calcium and phosphorus levels monitored regularly. Yes, that is a statement that reflects understanding, as we know that they should be managed. I mean, their manifestations should be managed better if there is frequent monitoring. We know that the hyperparathyroidism can lead into so many complications, especially hypercalcemia, right? If you answered letter D, secondary hyperparathyroidism is primarily caused by an overproduction of calcium. This is incorrect. This is not reflecting secondary hyperparathyroidism, but rather this is a primary hyperparathyroidism issue. So we are not selecting letter D. And also the reason here, secondary hyperparathyroidism is primarily caused by overproduction of calcium. That is not the correct answer. The hyperparathyroidism in the secondary hyperparathyroidism rather is not caused by the excess calcium, but it is caused by the hypocalcemia. Okay, cause of secondary hyperparathyroidism. I think it's time for lunch. I'm already getting a bit disoriented. Okay, so we are eliminating letter D. Letter E, increased levels of fibroblast growth factor 23, or known as the FGF23. What does that mean? This is a lab data that is only elevated if they have a continued hyperparathyroidism. Again, the increased FGF23 is incorrect because this will only reduce the parathyroid hormone levels temporarily. But when the CKD is progressing, there will be much more of resistance to this growth factor. So it's no longer going to be effective for this patient. Again, guys, letter E is incorrect because if there is elevation of the FGF factor, this is only going to be effective during the early phase. This is only going to this is only going to alleviate the manifestations of hyperparathyroidism during the initial phases. However, we know that the CKD is progressive, right? This is no longer going to be beneficial because there is going to be a resistance to the FGF, as the CKD is a chronic disorder. It's not something that is treated for, let's say, a minimum amount of time. No, it is a progressive type of disorder. And so this is not going to really have a long-lasting effect. Okay? So that is incorrect. So we have our correct answers here, A, B, and C. Let's have our last item of the day. A 49-year-old male patient is undergoing evaluation for secondary hyperparathyroidism. Which of the following lab findings are consistent with this condition? Is it A, high serum calcium levels and low parathyroid hormone levels? B, elevated serum parathyroid hormone levels with low normal serum calcium levels? C, low serum phosphorus levels with elevated 25-hydroxy vitamin D? And letter D, serum 25-hydroxy vitamin D level of 15 nanograms per ml, indicating vitamin D deficiency. Take note, guys, your patient has suspicion to have secondary hyperparathyroidism. So you're going to pick that laboratory test that will support this condition. Secondary hyperparathyroidism. If you answered letter A, high serum calcium levels and low parathyroid hormone levels, what do you think about that answer? Elevated serum hang on a second here. Which of the following lab findings are consistent with this condition? Remember that you have a patient that has secondary hyperparathyroidism. So if you selected A, high calcium, low PTH, this is not typical on a patient with a low parathyroid hormone. This is not a typical manifestation of a patient with a secondary hyperparathyroidism. Okay? We remember, guys, secondary hyperparathyroidism, what I'd said earlier. This is caused by what? Hypocalcemia. Remember what I said earlier about CKD? The patient in renal failure, remember about that. This is a type of a secondary hyperparathyroidism. One of the causes, rather. When a patient has CKD, remember that their calcium level is decreased because they have low vitamin D secretion. And when we are testing their PTH level, what they're going to have instead is a high level of the PTH, because this is a compensatory mechanism by the body in order to cause shifting of the calcium ions from the bone structure into the bloodstream. So if you answered letter A, which is reflecting low PTH, this is incorrect. They should have an elevated serum PTH. Okay? And they will have low to normal serum calcium levels. Again, a patient that has secondary hyperparathyroidism will tend to have an elevated PTH in response to the hypocalcemia. When we are going to check their calcium level in their blood, they will show low calcium to normal calcium. So it will have that quite of a range, low to normal. This is expected in the patient with secondary hyperparathyroidism. If you answered letter C, low serum phosphorus levels with elevated 25-hydroxyvitamin D, take note that 25-hydroxyvitamin D is what we call as the active form of the vitamin D, right? This is going to be low, not elevated. So this is also incorrect. Now, in a patient that has secondary hyperparathyroidism, they will have a varying serum phosphorus levels. So it's not really going to be a consistent low serum phosphorus, but varying values. It's not consistent. If you answered letter D, serum 25-hydroxyvitamin D level is 15 nanograms per ml, indicating vitamin D insufficiency. What do you think about that? This is actually an incorrect statement. The value that is 15, take note of the number here of your vitamin D, hydroxyvitamin D, 15 nanograms per ml. So, if you didn't know about the normal value of the 25D hydroxyvitamin D, the value is actually between 30 to about 100 nanograms per ml. The patient's value that is 15, it's way below the normal range. This is signifying vitamin D deficiency. So we don't have any other correct option, right? But letter B, elevation of the PTH and low to normal calcium levels. Yeah, quite a challenging type of test questions here. Again, the reason for that is basically it's because it's not really a commonly discussed type of imbalances. So if you find this very difficult, kindly review this video so you will understand really the mechanism. But back to Boss Babe. Is Boss Babe still around? Let's go back into that diagram. This is where we should go back to if in case you get confused with the mechanisms. All right? So this is the body's normal compensatory mechanism. So take note about the regulation. This is the normal compensatory mechanism if in case there will be hyperparathyroidism or hypercalcemia, or there is hypocalcemia. Remember that the parathyroid gland is much involved in the regulation of the calcium in the body. Can you explain how calcium is going to be low in hyperparathyroidism? It's actually not going to be low, AGI. I'm not quite sure why you are saying that the calcium is low. No, the calcium is not low in hyperparathyroidism. What causes the hyperparathyroidism? One of the causes of hyperparathyroidism, especially in secondary type, is hypocalcemia. The low calcium level in the bloodstream can stimulate the parathyroid gland to release the parathormone. Remember about this diagram right here? Take a look into this imbalance. If in case the calcium level drops below 8.5 milligrams per DL, or even below that, the body will maintain homeostasis by stimulating the parathyroid gland to release the parathyroid hormone. Okay. This is going to allow the body to get those calcium ions from the bone matrix. This will allow them to shift into the bloodstream in order to at least normalize the low levels of the calcium. Okay, and this will allow some more effects. It will allow the absorption of the calcium in the intestines. It will also allow the reabsorption of calcium in the kidneys, and this will normalize the balance. Now, if we are asking about why there is going to be how calcium going to be low? No, AJ, the hyperparathyroidism will not lead to hypocalcemia. It will lead to hypercalcemia. I'm correcting you in that one, okay? So make sure, remember about the effects of the hyperparathyroidism. This will allow increasing bone resorption. It will pull those calcium ions from the bone structures into the bloodstream. It doesn't cause hypocalcemia. So I hope that you are able to retain that concept. Alrighty, guys. Boss Babe, are you still around? If you're not around anymore, kindly comment in the video, in the comment section. If you are still not getting the explanation, let me know so we can review this sometime. All right. So I hope that you were getting some clarification in some items. If you haven't really, if you are getting more confused, please ask that question into the comment section so we will be able to clarify in the next section. Again, thank you guys for your participation today, and I'll see you again tomorrow. We'll be discussing another topic, another system. So thank you, and you have a great day, have a great evening, or a great afternoon. You take care. Bye-bye.